Hello, I'm Dr. Shlomit Schaal. I'm the Chief Physician Executive here at Houston Methodist. Welcome to our webcast, Women in Surgery, where we highlight the very best surgeons at Houston Methodist. All of them just happen to be women. And today, I welcome Dr. Amina Malik to the webcast, and you are the Chief of Oculoplastic Surgery and Reconstructive Surgery here at Houston Methodist. Tell us a little bit about yourself.
Sure. So first of all, thank you so much for having me on the episode today. It's very inspirational to be here with very inspirational female ophthalmologists like yourself. So I'm originally from Cincinnati, Ohio, where I was born and bred in the Midwest. And I was inspired to pursue medicine really by my father, who's a physician. And he is a urologist who came here from Pakistan in 1964 with a $20 bill in his wallet. And they called it residency then because he actually lived in the hospital. That was his residence. And so from him, I really saw the value of hard work, but also really the joy and satisfaction that pursuing the field of medicine can provide. So I knew early on that I wanted to do medicine. And so I, straight out of high school, went into a combined BSMD program. So it's a 6-year program. So saved a couple of years in my undergraduate years, which was nice. And that was in Northeastern Ohio with NEO-UCOM. And then I pursued an ophthalmology residency and oculoplastics fellowship, both in Cincinnati at the University of Cincinnati. And from there, I took my first job at Houston Methodist, and 10 years later, here I am.
Fantastic. So your father was a urologist. Was he disappointed that you turned out to be a urologist?
Well, I did do a urology rotation during medical school, but definitely ophthalmology beat urology in my opinion. But surprisingly, they did have some similarities with them both being fields that have a combination of both clinic and surgery, which was really something that appealed to me in ophthalmology. So, I don't think he was too disappointed.
So you knew that you wanted to be a surgeon?
Yes.
So how did you know that you're going to be good at it?
Well, I will tell you, do you ever really know anything until you try it? No, but I've always loved working with my hands. And early on in my residency, actually starting early on in medical school, I shadowed a ophthalmologist and an oculoplastic surgeon. And I sort of fell in love with the field, and they allowed me to do a little bit of suturing even as a medical student, and I got positive feedback. So I started that sort of encouraged me to further pursue it. And then, like all things, practice makes perfect, right? So, in the lab during residency, practicing on pig skin and all of that, the suturing skills to sort of get here where I am. But, I knew early on that I wanted to use my hands and felt confident that I could do it.
So ophthalmology is different than other surgical specialties. I have viewed different surgeons here on the show before, and most surgeries are kind of big. This is a small organ, right? The eye, only 4 cc's. I know what you do is a little bit more extensive, and we're going to talk about it a little bit more. But tell us about, the intricacies of ophthalmology as a profession, if you had to compare it to general surgery, transplant surgery, and even urology.
Yeah, totally different. And even to oculoplastic surgery, really, ophthalmology, it can be quite different because it's very fine surgery we're talking about very thin anatomy, microns in thickness with many of the tissues we're dealing with when it comes to the cornea and the retina, the sclera, very fine passes, meticulous surgery that really requires very steady hands given the nature of how delicate the anatomy is, and, not a lot of gross movements like you might be able to get away with some of the other bigger surgical fields. So it really is a very fine surgical field.
But oculoplastics is more than just the eye, right? So tell us a little bit what it is.
Absolutely. So oculoplastic surgery, that requires a 2-year fellowship after completion of the residency. And it really deals with all of the tissues around the eye. So it's a little bit tough because you are giving up really the bulk of what you learn during residency with cataracts and sort of the general ophthalmology diseases. diseases, but it focuses on, again, the tissues around the eye. So that includes the upper and lower eyelids, the tear duct system, the orbit, diseases occurring behind the eye, as well as aesthetic rejuvenation of the face. So it's a really diverse field in terms of what we get to see and treat. So it's really fun. And really what drew me to it was the diversity of the procedures we get to do. In any given week, I can do, 10 different cases, which keeps it really interesting.
So the eyelids, the orbit, and you talked a little bit about skin. So really a combination of bones and skin and fat tissue and also the vasculature around it. So do you rotate with other specialties during your fellowship other than ophthalmology?
Definitely. There is a lot of overlap between oculoplastics and other fields, including ENT, as well as dermatology. And I did rotate during my fellowship with both of those specialists. Within dermatology, there's overlap with some of the aesthetic things we do, such as lasers, fillers, Botox. But also from the medical standpoint, we're in Texas, a lot of sun exposure, so I see a lot of skin cancer. And the eyelid is a common area that we can see it, in particular the lower lid, which doesn't have the same protection from the sun like the eyebrow. And so for those, that they are treated surgically with excision by a Mohs dermatologist that are then reconstructed by oculoplastic surgeons.
So you have to work as a team. Are you working as a team with a dermatologist here?
Yes, I have several Mohs surgeons here at Methodist who I work with and in the community where, they will remove the skin cancer and then I will reconstruct it. And then I also work with ENT very closely. I'm a part of their department as well. There's a lot of overlap in several diseases we see, including thyroid eye disease, when we do surgical decompressions, work with our sinus colleagues, and then also for endoscopic DCRs, we work together on those as well sometimes. And then when it comes to facial aesthetic surgeries, we can combine some of our lower lid blepharoplasties with endoscopic brow lifts or facelifts, to help give our patients their rejuvenation.
So we talked a little bit about rejuvenation. So, the plastic or cosmetic part of oculoplastic surgery, do you feel that it's different or the approach to it is different in different parts of this country and the world?
Sure. So, beauty can be very subjective for patients, right? And for even us as providers. And so I think if you look at certain parts of the world and what some of my colleagues do for their surgery and what they consider beautiful might be different from what someone perhaps in rural Texas would consider beautiful, or to my colleagues in Beverly Hills, who are doing eyelid surgery. So while a little bit of it is subjective, I think there are some basic features that, and research has shown there are certain things that we look for when we look at each other that define beauty.
And what are these?
Well, that can include symmetry. The more symmetric faces can be, that can make it more beautiful. When it comes to the eyelid area, having open eyes, that's part of what I treat is when patients have closed or droopy eyes. That can not only affect their appearance, but really their ability to read and drive. They can fall asleep more easily because they're more tired from their lids being closed. That can also be a sign of beauty. Having redundant upper lid skin that's, hanging beyond the lashes as well, which can be treated with blepharoplasty surgery to remove the skin. And then when it comes to the brow, a female brow typically has a high arch sort of at the lateral 2/3 there, whereas a male brow is a little bit lower and flatter. So there can be things we can do to sort of shape the brows. And then for the lower lids, having a smooth transition between the lower lid to the cheek can be considered more of a sign of beauty. Part of our aging process, and often just genetics, can be when we develop bags under the eye, and patients can seek surgery to sort of help improve that.
So I'm wondering, are your customers, your patients, are mainly female or there's a nice mix?
So actually there is a nice mix. Being at Houston Methodist, a tertiary referral center, I get patients really from all over, as you know, and when it comes to like cosmetic surgery, probably a slightly higher incidence of females, but that's maybe about 1/3 of what I do. 2/3 of it is functional and medical. So I have a fair number of male patients as well.
So how about women in the field of ophthalmology? When I went to residency, that's a million years ago, it was majority male-dominated field. And now if I look at the statistics, it's half and half. Why do you think more women are now pursuing ophthalmology and oculoplastic surgery?
Well, I think for one thing, there's more women in ophthalmology that can mentor some of the younger generation and sort of show them that, yes, there is a role for you here and it's a great field, and help support and promote women in entering the field. And I think, lifestyle can definitely also play a role. For me, I knew I wanted to have children. My husband's an interventional radiologist. I wanted to have a career where I could still, work and make a difference in my patients' lives and get fulfillment out of what I do, but then still be home most evenings to be present for their games and sporting events and on the weekends. And it is a field where we have relatively few after-hours emergencies compared to some of the other surgical subspecialties. And so I think that can be a definite draw for some women in ophthalmology.
So did you have mentors, female mentors?
So it was interesting. When I did my residency, I was when I first started, I was the only female, and there were 11 male. So of the 12 residents, I was the only female. And my department was a very similar representation where we had 2 female faculty. One was part-time in our whole department. So I, during my residency, did not have a lot of female mentors, but I did have male mentors who sort of helped support and, guide me towards getting here. But then once I became an attending, I sort of on my own sought out women in the field of oculoplastics who, I respected, and individually reached out to them to get career advice, input on their road to getting where they were.
And does it help now that in your own department there is a majority female?
Absolutely. Yeah. I think that's really encouraging that we are the majority female in our department. It's great because we have diversity. It's great because we have a very diverse department, which we know can translate to better patient outcomes, in more innovative research. And overall, it's a very great group of colleagues to work with.
So I know it's a short period of time, only 10 years after you graduated from your fellowship, but in your short decade, what has most impressed you? What has been the greatest advancement in your field? What has happened that kind of wowed you? I know you're a generation that it's difficult to wow you guys, but...
Yeah. So when it comes to my field, in terms of the practice of oculoplastic surgery, one of the biggest advancements I've seen is finally having a medical treatment option for thyroid eye disease, which did not exist prior to 2020.
So tell us a little bit what it is about.
Sure. So thyroid eye disease is a very big part of my practice, where patients can develop this autoimmune condition that can affect their eyes. They can have blurry vision, double vision, eye pain, redness, significant bulging where their eyes become widely open, and that can have a huge psychosocial burden as well. And it's an inflammatory condition which really there is no cure for, and it can be chronic and progressive. So prior to 2020, steroids were sometimes used, but the disease would flare and it wouldn't really always be effective. And then we could do surgery to make the eyes less proptotic or bulgy, and we can do eye muscle surgery to straighten the eyes, lid retraction surgery to make them less widely open. But these are several surgeries with recoveries and their own risks. And in 2020, there was a drug that became available, teprotumumab, which is the first FDA-approved treatment option, which can be really effective at sort of treating many of the manifestations of the disease, including the double vision, the pain, the bulging. So it's a really exciting option for those of us who are treating thyroid eye disease and for patients. And here at Methodist, we're actually working at developing the first multidisciplinary treatment center for thyroid eye disease with ENT and endocrine to really help improve our patient outcomes. And we're also participating in some of the clinical trials for some of the new and up and coming thyroid eye disease treatments, as there are several other antibodies that are being tested for the treatment.
So less people need surgery as a result?
Yes, that is what we're seeing. There still is, of course, a role for surgery. There always will be. But I think most patients, when we ask them, would you rather do a medication first or a surgery? There have been studies that 8 out of 10 are going to choose the medical option first. So it's exciting that now we have one.
And if you have to do surgeries, it will be a lesser invasive kind of surgery, right? You're not going to go inside the orbit and take away the fat and move bones and things. You're going to do something less invasive?
So there are different types of orbital decompressions we can do. So after they've had teprotumumab, we theoretically might be removing just one of the orbital walls or just fat. So it's less risk for the patient.
And how does this medication work? What's the mechanism?
Sure. So it's an instant light growth factor receptor blocker. So if you go back to sort of the pathology of thyroid eye disease, on the orbital fibroblast, there's an upregulation of some of the receptors. And so the medicine actually blocks the binding of your natural antibodies to that receptor to prevent the downstream inflammatory cascade, because it's that binding to the receptor that sort of causes all of the increased fat around the eye, the swelling, the enlarged muscles. And so you're kind of stopping it right at the start. And it's given via an IV infusion every 3 weeks for a total of 8 infusions. And it's something we're offering here in our clinic now too.
That's amazing. So, to me, it's always amazing how medicine advances. I still remember my boards exam here, the oral board exam where they asked me about thyroid eye disease, and I had to kind of memorize, even though I'm not an oculoplastic surgeon, I had to memorize what to do. And it's always sounded so complex. And I always thought they should find a medicine,
Right.
A medication for that disease. And it's just amazing that this happened, and it's actually moving forward beyond that, correct?
Yeah, exactly. Now we're going to be studying oral and even just sub-Q options. So perhaps not needing to even come in for infusions.
Fantastic. And so let's talk a little bit about the surgical side. Are the surgical technique also evolving, not just for thyroid eye disease, but in general, oculoplastic and reconstructive surgery? Have you seen evolution in the techniques, maybe the instruments that you use? Has it become more sophisticated and less invasive, or did it stay the same?
So I would say compared to cataract surgery, we probably haven't seen as many changes with the laser technology and all that we've seen, with the general field of ophthalmology. But within oculoplastics, there have been advances with the development of laser for incisional blepharoplasty, where we can use the CO2 laser to make our incisions, where we can theoretically have less bleeding for patients and less bruising in the post-op period. And so that has been one sort of advancement with regards to the instruments. In addition, for orbital reconstructions, when we have patients who have trauma and they have orbital fractures, there's new technology where we can actually use their scans to make custom implants that are patient-specific to really fit the specific fracture site and really lead to improved outcomes for our patients. Because prior to this technology, we would just sit there with a little hemostat and try to mold our implant to fit the fracture defect and kind of go back and forth until we get it. But now there is this system that allows us to have patient-specific implants so that there's not a lot of intraoperative adjustments, which can lead to improved outcomes.
That's amazing. Tell me a little bit about patients that actually lose their eyes and you have to have an artificial eye. What is an artificial eye? And do you have these patients in your clinic?
Yeah, so doing enucleation or eviscerations, both of which involve removing of the eye, is a big part of what I do. And reasons that we sometimes have to perform this surgery is either due to a blind, painful eye. So if patients, let's say, lost their vision several years ago, either from an injury or from diabetes or glaucoma, their eye can become tisicle, where it becomes shrunken and small and painful. And so when that pain is significant, then we remove the eye. That sort of removes the inciting agent for the pain. And then in addition, sometimes patients might have cancers behind the eye or in the eye where we need to remove the eye as well. Or if they've had trauma, that it's really where there would be a risk for the sympathetic ophthalmia in the other eye, we try to remove that eye in the early post-trauma period to decrease the risk of that. And so when we do that surgery, we put a ball implant in the place of the eye. And the purpose of that is to provide volume in the area where the eye has now been removed. And so there are different types of implants that can be used. I like using the silicone implant. So it's just a little spherical ball. And then we will sew some of the tissue that is left behind after we remove the eye, so the sclera or the conjunctiva, to cover that implant. And then after about 6 weeks, patients can go see an ocularist who are very talented people who I work with here in Houston, who will hand paint an artificial eye to sort of match the opposite eye. And they do a phenomenal job where medical students will often be shocked, when patients come in and learn that one of their eyes is an artificial eye.
Amazing. And do these enucleation and eviscerations become less and less common? I would hope so, at least. Do they?
Are they less common? Well, yeah, I feel like I still see a fair number of these, unfortunately. But, in 10 years of practice, gosh, it's not my most common procedure by any means, but I'd say, probably 5 or 6 a year. So,
yeah. So that's less common than I've seen.
Okay, well, good. Yeah, I think it's been kind of steady for me, but that's good that it's less than when you were practicing.
Fantastic. So tell me a little bit about this balance between being a busy surgeon and having patients and surgeries and other duties. That this is an academic medical center, so we have teaching duties and maybe research duties, and your role as a mom.
Yeah, that's a great question because, that balance is always really hard to achieve. But I think, it's always sort of a work in progress. For me personally, having really good help has been key. I have nannies at home who, when my kids were younger, were able to help. Now that they're in school, they can also help with like pick up and drop off and that part. But in general, I think ophthalmology is a great field in that, as I was saying, I'm home pretty much every evening for them. But I definitely have those evenings where I have conferences at night, or I have meetings where I'm presenting and, don't want to give up those opportunities either because, now is the time when you're getting them. And so while that's also the time I want to be home, I just have to remind myself that I'm showing my children that, women can be moms and be ophthalmologists and educators and researchers. And I feel like they have always been very supportive, actually. They're almost 12, 8, and 5 of me working.
And your husband is also a physician. So tell us a little bit. I mean, I always said I'm never going to marry a physician because I just thought it would be too complex and too impossible. But then tell us a little bit, is the gender playing a role in, what he does versus you? Or is this the specialty that plays a role?
Yeah, and I failed to mention that with your last question, but that's just a huge part of being able to do everything I do is having a supportive partner because while he is in medicine and it's very busy for him, we both understand what it's like and know what it is to be a doctor and, what we're doing. And when we're not there, it's for a reason. And so having that support has been really nice. And he is wonderful in terms of sharing some of the responsibilities. Summer camps, he does all every year. He books the summer camps, which is great. He is very involved with drop-off every day. He, helps sort of balance that load of parenthood. It's funny when I get emails from either the nurse or the teacher and it's only CC'd to me. I'm like, why is the husband not CC'd here? Like, this is a parent. We're both the parents, right? Like, we need to be dividing the responsibilities. And I feel like I've been really blessed in having, a partner who sees that and it's been great for my career.
I wanted to ask you, you are now in a position to mentor others. Do you mentor people? Do you mentor women?
Yeah. So I feel like mentorship is very important in terms of even getting more women in ophthalmology. So I'm involved in several mentorship programs. ACOPers, which is our National Oculoplastics Society, has a mentorship program where I am paired up with someone who's just straight out of fellowship to be able to talk about, career advice and motherhood advice, all of the things, as you navigate those first few years of attending hood. I'm also involved with mentorship through Women in Ophthalmology, where we're paired up with trainees.
I'm going to see you there this summer then.
Yeah, I'm excited for San Diego.
Yes.
Yeah, that should be fun. And so I'm paired up with a resident who I, again, am talking to just about the match process for various fellowships, tips on how to succeed in residency, taking the examinations and all of that. And then within the broader American Academy of Ophthalmology, they have the Minority Ophthalmology Mentorship Program also, which is great in terms of helping with underrepresented minorities and allowing them to have more access to study materials for board preparation, as well as networking opportunities and research opportunities to also increase their presence in the field.
Yes, I feel that we have made a long stride in terms of women in ophthalmology, but not so much in diversity. So, I was always a supporter of the MOM program and thinking about what we could do more to make our profession more diverse, because we know that patients would like to be treated either in their own language, from their own culture. They would like to see options of which ophthalmologist to choose. And we don't have that diverse presence all over the country yet.
No, we need to get there though. But I've been happy to see in our department we're at least doing quite well when it comes to diversity, considering Houston is the fourth most diverse city in the country to help, meet our patient needs.
Correct. This small ophthalmology department that we have here is quite diverse in terms of both, gender and race, which is great. And I know you guys speak different languages, which is also great. What advice would you give, the younger you?
So my advice to my younger version of myself would be, to stay focused, to work hard, and to know that even though the journey to getting here is long, it's definitely worth it. To look for opportunities around you, to be involved in research and society, organizations, volunteer, get your name out there, get to know senior people within the field, to look for more of those mentorship opportunities. And when it comes to parenting, yeah, they can be done. It's not always easy, but it's definitely worth it in the end.
Yeah, I have 4 girls, as you may know, and I was worried about them, like my entire life, my entire career. I thought that they would not turn out okay, but now I can tell you they're wonderful and fabulous. And, despite me being very, very busy like you have been. So the kids are going to be okay.
That's right.
Thank you, Dr. Malik. This has been fantastic to converse with you about ophthalmology, the very best field in medicine, if we say so ourselves.
That's right. No bias.
And I enjoyed the conversation with you. Thank you for coming.
It's my pleasure and honor. Thank you for having me.
And thank you for watching. I hope you enjoyed this episode with Dr. Malik, and see you next time.